Hello, welcome everyone. We are here today with NCH and Ciccarelli Advisory Services. My name is Dakota and I will be kicking everything off. And first I'd like to go over how the GoToWebinar functions work so you can have the best audio experience during this webinar. So first, I'm going to explain your control panel, and this is going to help you to submit questions during it. And it should be the box that popped up at the very beginning. It's the little box on the side, and it should have questions as well as audio. And that's where you're going to be submitting your questions. It also should have icons that pop out of the side, and going from top to bottom, it should have a computer screen, a hand, and a microphone. After that, if you need to, you can use that computer screen to put yourself into full screen mode, and that's what we recommend during this broadcast. Throughout the presentation, you can pose your questions into the question box, which is below audio, and our presenters will try and cover as many questions as possible. At this point, I will shift things over to our moderator, which is Kim Ciccarelli-Cantor, and she will be introducing our speakers today.
Thank you, Dakota. Welcome, everybody. We've got folks attending from really all over the country, so very pleased to have you here. Those of us in Florida are a little hotter than some of you in other parts of the country, but good afternoon, welcome. We have found that health, family, wealth, faith, these are many of the priorities that we hear from everybody and we all share together. And today's webinar is actually going to concentrate on the health and wellness area. And as it relates particularly to our community, though I'm sure our guests will share what's going on around us as well. It's been approximately 6 months that we have been going through this COVID world of affairs, and we have learned much during that time. Fortunately, from what I'm understanding, is trends are continuing in the right direction. And again, our guests will share great insights to this. Many professionals, such as our company and others out there, are at a work from home mode. So much of the interchange and engagement has been virtual. This has been new for many folks. And today, of course, we are seeing students return to school, so that's opening up also a lot of areas out there for how do we deal with safety concerns, as well as sports. Sports started up recently as well. So we're seeing more economic activity. There's no question that we had more spending, and we did at Ciccarelli Advisory Services and others too expect that bounce back in the economy initially, though after, we're opening up here, we would expect things to slow down somewhat going forward, at least in the immediate future. Unemployment still remains very high. Much has been learned about the virus. There's new information coming out all over the place regarding the potential situation with a vaccine. And I heard recently that though Europe, as an example to the US, Europe has seen an increase in reported cases, but I understand no fatalities. Fatalities are down greatly. And someone had mentioned a statistic recently to me that 48 of our 50 states we're experiencing a transmission rate of 1% or less. I'm sure we're going to learn about what that means. So as we're looking for, I'm really looking forward to our guests. So I want to now turn it over to our Chief Executive Officer of NCH Healthcare Systems here in Naples, and Dr. Kristen Mascotti, who's our Chief Medical Officer. So Paul and Kristen, please take over.
Kim, thank you so much, and we're very pleased to be here with you and your clients. I really want to start by thanking so many of your clients have been so supportive of us through this pandemic from February and right up until now, and they've helped by donating money and donating supplies and donating meals. So we've had just the generosity and your clients have been foremost among those generous folks that have helped. One thing we've learned about this pandemic, it is truly a community effort. You know, we happen to be in the leading healthcare system taking care of the sick people, but without the support of the business community and the philanthropic support we've received, we couldn't do this. So I'd start today by addressing those of you who are on your way back to Florida or considering coming back to Naples. You may be wondering, what are you going to find when you get here? Contrary to what you hear on the news reports, we're not overrun with COVID patients in Southwest Florida, I'm pleased to say. We peaked in Southwest Florida with COVID patients the last week in July, and it has been steadily declining since. So at one point, Doctor, we had, I think, 165 COVID positive patients being treated in our hospitals. That number is down to about 21 or 22 today. So you see it's dropped fairly dramatically. The positivity rate is the other thing you'll see. The testing positive, we're down in the single digits, and at one point that was in the mid 20%. So good news is the disease has declined significantly. We have plenty of hospital capacity, so if you're worried if you did get sick, could you come to the hospital? We never did run out of capacity here at NCH, so our board was very adamant that we would have adequate supplies of the PPE, the personal protective equipment. They were adequate. We want to have adequate ventilators. We've never run out of ventilators. ICU beds. We never were short of nurses or doctors or hospital rooms. So all that is in place, and we are prepared if, God forbid, there would be a second surge. We feel very much prepared for that. We've got 7 months of PPE on supply here in case we would need more. We've got plenty of rooms and plenty of personnel. The other point I would make is it's safe to come to a hospital. Should you be fearful of catching COVID if you come to a hospital? The good news is, since the beginning of this pandemic of treating thousands of patients, we've never had a patient get infected from another patient, so no cross-contamination. We've only had one employee infected by a patient since the beginning of this pandemic, and that employee has fully recovered and is back to work, so we're pleased to say that. So the bottom line is we have capacity when you come back. It is safe to come in. We've taken many precautions, and some of you have donated funds for these germ zapping robots. You know, we now have 13 of the germ zapping robots that kills coronavirus, kills MRSA, kills C. diff. We have a very safe hospital here. We have negative pressure rooms, and we've taken all kinds of precautions around the cleaning of rooms and around the social distancing. So again, safe to come to NCH, plenty of capacity if you should need it. The disease is definitely on the decline, and we feel well prepared for whatever might happen. So lots of good news on that front. And we're going to talk too, you had some questions about vaccinations and some other topics, and I'm going to introduce my colleague, Dr. Kristen Mascotti, and ask her to address a couple of those. So Dr. Mascotti is a board certified pathologist with a background in clinical quality improvement. She has served as a chief quality officer, as a chief medical officer. She's been on board here for 4 months. She's still smiling. She's making a big, big impact in a number of different areas. But Kristen, one of the common questions is in this theme of two things. The current state of testing for COVID, what's going on with testing? Number two, what can you tell us about the prospects for a vaccination for COVID? And what are you hearing clinically in that regard?
Sure, thanks. And thanks for the warm welcome. I've actually enjoyed my time. It's a great team here, so very excited. I'm a Minnesota native, so did spend some time in Florida and was very well aware of Naples, so I'm happy to be here. I think a couple things before I get to those questions that I just wanted to highlight, just as an outside view for those on the phone and the Zoom, is really what NCH has done in terms of their clinical care of the COVID patients. So along the lines of testing, again, I came from California, and we we're talking not only with the team here at Naples, but also throughout the country as to testing and how to get that done appropriately. NCH had a very large luxury that we didn't have in California or Minnesota, which is they had availability of testing quite early, and then they had the availability of antibody testing to look at all of our employees to see if they've actually had the disease and check the antibody testing, as well as then roll that up to the community. So that's not something that many communities have, that we in fact have the luxury of having. So it's a little bit about the testing. The other things in terms of how NCH has set up their approach to COVID that was shows the great outcomes is really this hospital within a hospital. So we have units where COVID patients go that are separate from other units, and that's all based on the testing at time of admission, and they've done a fantastic job with all of that. The other thing that we've done particularly well is we brought together a physician leadership team with our chief medical officer, myself, as well as our nursing and operations, and basically looked at the best literature out there in the country using our Mayo Clinic affiliation. And I think we were really able to employ a lot of the early treatments that were effective, again, very early. And so what we found is that the national survival rates, we actually have about somewhere between a 10 to 20% improved survival for COVID due to our critical care docs and our teams, and really having the group come together to listen as to what are the best practices and when do we need to employ those, because this was a very different disease and we needed to learn a lot at the beginning. And we definitely put in some of the things that were proven to be effective a little later on. We did that more proactively, and I think our combined approach really served our patients well.
So you're saying the patients treated for COVID here actually did better than they did in many parts of the country based on our treatment protocols and on our care teams?
Absolutely, and I think it was the approach to ventilation, the early use of steroids, as well as different drugs at different times. We also had availability of the plasma, which I'm sure you've heard in the news, the convalescent plasma. So if you recover from COVID, you're able to donate your plasma, which contains antibodies that fight the disease for the patient who receives it. So we did that very early, and that was very effective. So we're still trying to figure out everything we did right, but at the end of the day, we did it all and we did it early, and our improved survival proves that.
And I know you're in touch with the pharmacy and so forth. In terms of looking forward, do we have adequate supplies of the drugs that are being used to treat COVID right now?
Yes, we do have adequate supplies of the drugs needed to treat.
Oh,
so that's obviously great news.
Another line of questioning had to do, and it's in the news a lot, is the vaccination. There's several in testing. Can you talk a little bit about vaccinations? And I know you've made a recommendation, which we've taken to heart. We've just purchased some of the big cooling rooms to house vaccinations as soon as they're approved, which will allow us to be a distribution center for the vaccination. But can you talk a little bit about the vaccination?
Sure. So I think there's a lot of hope, and we have a lot coming down the pipe. We're hoping for maybe end of 2020, beginning of the year for some of the first vaccinations. So we'll definitely be working with our local, state, and federal governments so that we're, again, as Paul said, ready to receive those. But still, in terms of exact timing, we don't have that information, but are obviously actively interested in it. I think along the lines of vaccination conversation we had earlier this morning, we had a Zoom community meeting with COVID and heart disease and talked to a few of our cardiologists. And we are really making sure that the community is aware that we still need to do our vaccinations for the flu shots and make sure that we have that in order now. That's something we can do while we're waiting for the vaccine nationally for COVID.
Do you have any thoughts, Doctor, about the flu season and whether we would expect that to be worse or better than historical flu seasons, or do we know?
No, I don't think we know. I think it's going to be fascinating because never before in history have we done social distancing, have we done masking, have we done such a tremendous job with hand hygiene. So I think it'll be fascinating to know if it's actually sort of there's a less flu because of all of our precautions we've taken with COVID, but that's to be determined. There's still flu, it's obviously separate, but I'm very interested to see if we have a smaller flu year based on all of our precautions we've put in throughout the communities.
And Kristen, the schools opened here, I guess, 2 weeks ago, roughly. Private schools 1 week, and then the next week the public schools open. Have we seen an increase in any activity either with students, teachers, or do you think that's had a big impact, or do we know?
No, so far, and I say this gingerly, we have not seen. Our big uptick was after the 4th of July, and that was where our numbers followed about 2 weeks, 3 weeks later. So school is in session, colleges are in session, and we have not seen so far the same type of uptick. Now, I think it is, even the college students nationally are going back with masks, they're going back with hand hygiene. So I'm hopeful the social distancing and all the parameters that we know to work continue to be effective.
So that's something we'll continue now. And as it relates to schools, NCH, about 2 months ago, we did help some businesses come back online. We've been working very closely with the chamber here to help and advise them. But members of your team, I know, were working with the schools here. Can you talk a little bit about that process and how that worked with the schools coming back?
Yeah, absolutely. So the schools asked for our input, which I thought was great. And we provided our experts to talk to the schools in terms of at what rates are kids infected, is it less severe, and what some of the recommendations would be to help the schools make that decision. And so we were able to do that. And I think that's another example of where, as a healthcare system, we can lean in and help the community make decisions just based on the information and data and expertise that we have from a clinical standpoint.
And as folks return back here to Florida from their northern homes, what are the medical experts saying about protection, prevention, and so forth? What can folks be mindful of as they travel back to Naples?
Well, I'm getting this question from family as well, because I'm encouraging them to visit over the holidays and the fall and winter. And basically that it's the same things that you're doing at home. Obviously, if you have either things like advanced age or underlying cardiac disease or things that, a cancer situation, if you have some increased risk factors, really it's about being incredibly disciplined about that in terms of social distancing as well as the masking and the hand hygiene. But I'm telling my family members that it's definitely safe to come here in Florida and to visit and to use the same kinds of discretions that they've been using in the northern states when they come to visit here.
Thank you. As far as testing goes, I mean, NCH is doing 2 different kinds of testing. I mean, the antigen testing and the antibody testing. Can you talk a little bit about what that is and what it means?
So it's a little bit confusing, and there are different types of tests. There's different ways we do the tests and how quickly we have results. So we can talk a little bit about that. The antigen test means I have the disease now. It's actually something we look for on the virus in the blood. So that tells us quickly if we have the disease or not. There's been a shortage nationally early on and sort of wax and wanes over the last few months with getting the reagents. So we have the testing instrument, but the reagents, what we use to basically administer the test, has been difficult for us to acquire. So based on how you come to the hospital determines how quickly you'll get your test result back. So if you need to be admitted to the hospital, you're symptomatic, you will definitely get an antigen test that tells us, do you have COVID right now? We can get that result very quickly, under 15 minutes. If you come to the emergency room or your doctor's office, you don't have symptoms, you will get a test, but it may take a little bit longer because we're saving those rapid turnaround tests, or it's actually the reagents, for those who we need for inpatient placement. So that's one type of testing that's done, and that's why sometimes it takes a week, sometimes it takes 15 minutes. It's really based on the acuity of your need in terms of coming to the hospital. The other type of testing we talked about that NCH was able to offer not only to patients, employees, and the community is the antibody test. So that means whether I knew it or not, I can tell from my blood draw whether I've been exposed and have antibodies, which is your body's immune system to fight the disease. So we have that testing as well. So we have about half a dozen different platforms because we've invested in not just one brand of antigen testing, we've invested in a multitude of them so that we can get reagents from multiple vendors to be able to have access to that type of testing. So it's something that I would consider a luxury that we have here, to have so many testing equipment with different reagents so we can keep the supply going. That has been a very crucial point in all of this. If we can't determine if someone has COVID or not when they come into the hospital because we don't have the testing, then we have to treat everyone as if they have COVID, which we do, but it ends up using a lot of our PPE. And that's where you saw the PPE being used at extraordinarily rapid rates in the beginning of this pandemic, because we couldn't accurately test.
And Kim, some of your clients too were involved in the donations that purchased some of this testing equipment. The antibody testing we conducted thanks to a donor that helped us get that done. But we did test our 5,000 employees here, and folks might be interested to know that after testing our 5,000 employees, who we certainly have been around a lot of COVID patients, less than 1% of our employees tested positive for the antibody, which we found kind of surprising. But I think it speaks to the fact that the masks and the social distancing does work. So, Kristen, can you?
Great to hear that. That's excellent.
Yeah, that was again, your clients and this community has been so helpful to that. Kristen, another question that's come in prior to our meeting today. Folks coming back asking, is it safe to have surgery at NCH? They have scheduled either total joint procedures or other procedures. First of all, is surgery open? If it is it safe?
Yes, surgery is absolutely open. That's something that we did, again, very well, because there's elective surgery, but then there's emergent and critical surgery. And so we definitely kept all of those going during the pandemic. So yes, it is open and it is absolutely safe. I think beyond us talking about how we've done all of this, it's really the proof is in the outcomes in terms of our patient-to-patient transmission rates, as well as our staff safety rates. So that it is absolutely safe to come back. In fact, some really interesting information that we talked about this morning with the COVID and heart diseases, there's some very new literature coming out showing the graphs of the usual rates people come to the emergency room for stroke and for heart attack. And in the month of March, you see just a precipitous fall off. And it's not because people weren't having strokes or heart attacks, it's because people weren't seeking care. And so one of the big messages around our community outreach, as well as our emergency departments, is to say we are absolutely safe. If you have something that's acute, heart attack, stroke, to come to the hospital. And if you have concern that you have COVID, the earlier we're able to treat you, the better off your survival and your overall outcome. So we did see a fall off in terms of people seeking care for critical needs, and we're as concerned about that as we are treating COVID.
Yeah, excellent point, Doctor, because we did have a lot of questions along those lines. And, you know, one of our concerns as a company serving so many families, so many retirees, particularly where families aren't locally here, where we anticipated, because of the quarantine, the isolation, the lack of engagement, movement, regular exercise, and things that people were doing, or that they would just be reluctant to see their doctor when needed or get that operation when needed because of everything that was going on, come March and going forward into April and May. So we did see a slight pickup in some concerns medically. So I think it's really important to get that messaging out, to get it out to the community and to people who do need to seek assistance, emergent or critical care or surgery. So thanks for sharing that.
And we had a call with this same group a couple of months ago, Kristen, and I wonder if anything new has come up scientifically in terms of susceptibility to COVID, who is most susceptible, number one, and whether or not there's more data on if you have had the disease, would you be able to get it again, or is this disease going to mutate and perhaps come in a different form? Or I know you're in connection with a lot of doctors on this topic. Can you update us on that?
Yeah, so great topic. So what we're learning, and the literature continues to evolve on this, is that basically a couple of what we call independent risk factors. So this is those that are highly predictable of risk by themselves. One is age, and we literally just went over that data about 2 hours ago with the community. I will make sure that you get the recorded seminar. It's on heart disease and COVID, because we talked a lot about this, but one is age as an independent risk factor. The inflection point to that, under 50, we know does very, very well, but as early as age 60, it almost triples. I think age 50 is about 1.3% risk of mortality, as opposed to over age 60, it bumps up to about 3.6. Oh, and it goes up each sequential decade. So age is an independent risk factor. Okay, Kristen, I can't control my age, agree. Another independent one is obesity, we're finding. And so there also are things like underlying heart disease, underlying lung disease, any immunodeficiencies or cancers. Those are things that put you at higher risk. So we did go over some of that, and I'm happy to dig a little deeper into that. But essentially what we're telling people is what can you do? If you're in one of those protected categories, that's where it becomes imperative to be pretty disciplined about the hand hygiene, the mask, and the social distancing. So depending on your category and your risk, to not only speak to your doctor, that's where I think really the best course of action is prevention, and then seeking care early.
Sure. A couple of questions that came in. One question was, if someone doesn't have symptoms, can they still get tested for the antibody to see if they've had it?
Yes.
Okay, and the other question that came in along the lines of what you're talking about now is someone who was preterm as a baby, does that make them more susceptible to this virus?
So I think preterm as a baby, we need to learn a little bit more. If they've really come out of that, many of these preterm babies do extraordinarily well and have no long-term effects. So unless you have something related to an immune system specifically or other independent factors, that has not come out as an independent factor.
Thank you. Another question that came in before I go back to Paul is, why is it that when somebody gets tested that you might have someone that'll test negative a couple of times but actually end up with the virus and can end up in a severe situation where they end up being hospitalized with symptoms, et cetera, but they had already tested negative a couple of times? What makes that occur?
So this is a great question. I would say the answer is twofold. One is early on, there was such a rush to market for these antigen tests that could quickly identify if I had the disease or not. Some of what we call the sensitivity and specificity, so that basically means the accuracy of that test was not great. So early on, some of the testing modalities maybe could only predict 50% of the time if that was true. So that's what testing is one issue. Now we've corrected most of that. Now, the actual long-term effects of the disease and how we can test and retest in different parameters is actually some of the natural history of this virus that we're still trying to understand. Because it actually can happen that way.
I just have one other question on COVID, then I want to turn to a couple of other topics that are near and dear to your heart, Dr. Muscati, about some clinical programming. But a question came in around intensivists. We're blessed to be the only health system in this region with full-time 24-hour intensivists. Can you talk about what those doctors are and how they play into COVID?
No, it's a great point. I think one of the luxuries that we have here is our intensive care, our critical care team. So when you need an ICU or intensive care unit service, they're one of the top 100 in the nation. And this is the team that I think really has done that work around our improved survival rates. So having an intensive care, this is a specialty of medicine that you do extra training for to get certified in how to take care of those critical patients at the time of their need. So we have 24-hour services for that. We also have 24/7 hospitalists, which again are doctors who specialize with extra training in taking care of patients in the hospital exclusively, which is different than just necessarily going to an outpatient clinic and seeing your physician. So we have the luxury of having our hospitalist program as well as our intensivist program. The two types of intensivists you're going to need most if it happens to be COVID is everyone knows lung. So we have our pulmonary critical care docs, which again are in the top tier performance in the United States. But what we're learning and what we just talked about was it's also heart. So we also have our critical care docs and our cardiologists. So we do have the luxury, and again, are exclusive in that, of having those kinds of providers and specialty training, which I think absolutely directly correlates to our improved survivals.
And so it's a great segue into a project that Kristen has taken on since she started here, Kim, is that we've just completed a deep dive look at our cardiac and cardiology program here at NCH. We brought in a company called Chartis to look at our outcomes, to look at everything related to interventional cardiology and heart surgery. We had a team of doctors from Northwestern in Chicago come in that interview doctors, look at the data and so forth. And I'm pleased to say we got very high ratings, very high marks from these cardiac experts. One of the reasons I think is, and you've educated us on, is post-surgical, post-heart surgery, post-heart procedure, we're blessed with these intensivists that really help people recovering from heart surgery or any kind of a heart procedure. And you may want to say something about where we want to go with heart surgery and cardiology.
No, absolutely. I think what we're learning in healthcare that works best is it's not just one episode. It's not the surgery itself. It's the entire continuum of the stay. So if we actually break down something like cardiac services or heart into three components, the first part is optimization, making sure that I'm as ready as I can be for my surgery. Now, if it's emergent, obviously a different scenario, but there's that making sure the patient's ready for surgery. That requires teams. And then there's an intraoperative team, anesthesia, with specialized training in cardiac, along with the surgeons and the interventional docs that do non-surgical approaches. And then there's the postoperative care, and that is critical to the overall success as well. And that's where we have the pulmonary, the cardiac, as well as our intensivists and hospitalists to help see the patient on their way home, and then some of the post-op rehabilitation. It's that entire continuum of care, and it takes a broad team of specialists to provide that care that are trained and working together. So it is a collaboration for the best outcomes.
So thank you for that. And one of the things we learned, Kim, throughout the COVID pandemic is we've gotten involved in some research studies related to the treatment of COVID. And we've decided that we're going to expand some of this research clinically. And we think that heart will be another area that we'll be getting involved in. And some, again, your donors will probably be made aware of this in the near future. We'll be looking to endow a few chairs in the cardiac and cardiology area, much the way universities would. But NCH, on our path to becoming a top 100 health system in America, will really begin by focusing on all things cardiac, cardiology, and stroke.
No, absolutely. And it's recruiting talent, it's growing the talent, keeping the talent we have here, as well as making the community aware of much of the outcomes and awards that we currently have. But that team approach through the whole continuum of care is really the focus and the service line that we're going to continue to improve.
And we talked earlier, you and I did, about something that's near and dear to your heart, a simulation center that is being developed here for the training of physicians and other clinicians. Can you talk about what is a simulation center?
Sure.
What are we going to try to do, or not try to do? What are we going to do?
Well, this is very exciting. Simulation centers are sort of a leading practice when it comes to patient safety and quality. So if we talk a little bit about how physicians are trained, it was sort of a little bit of an old mantra of see one, show one, do one. And so literally you read about it, you watched it, then maybe you saw your attending physician do one, and now the next one you did yourself on a patient. And So obviously, from a patient's perspective, it would be best if we could actually simulate that procedure prior to having a new person come and do that type of, whether it's put in a catheter, a central line, or that even do ACLS or do recovery. So these simulation centers basically take pretty highly, there's a lot of technology in these devices that allow me to actually place the catheter through skin and models to find out if I am able to do that appropriately. It's sort of like a pilot sim center. You don't just fly a plane, but we're doing this for medicine as well. And so that these simulation centers, we have a video that we've created. It's really impressive what we can do to train we have residents here as well as our staff and others in community into how to do these better. So it's really exciting. That's
excellent. And, you know, when you think about increasing the patient experience, enhancing it, increasing the quality, the clinical quality, all of those are very important, you know. So we're glad to see that. I have one question, and then I want to take a segue to what you were just talking about, but I want to make sure we catch the questions that are coming in, and this goes back to COVID. I'm not sure I understand the question, so I'm going to repeat it exactly as it came in, but how has treatment evolved since March? What are the current in-use options which NCH uses for COVID patients? Can you address that for us, Dr.?
Yeah, great question. It's evolved quite a bit, actually. So much of what we did learn from the New York experience. The way we usually treat patients with this type of severe infection was through ventilation. And we learned early on that that wasn't as effective. And so the other thing we learned about this virus early on since March is that it elicits a total body cascade of basically hormones and corticosteroids that it's called this corticosteroid storm, and it also causes clotting. And so this is very different than some of the viruses we've dealt with. That's why our use of steroids to calm the immune system's response down so it doesn't have all these negative effects, I think is part of why we've had such improved survival. So very different than we've treated other viruses. So making sure oxygenation is okay, but it's where you are in your disease, you have different ways to treat it. So if you're early on, there are different things we can do. Obviously, remdesivir, we have the corticosteroids. We've also learned a lot about the plasma. We were very early in doing convalescent plasma here, and it was quite successful. We're also learning, which again makes sense, if I've recently been exposed to COVID and I donate very shortly after I've been exposed, I have a very, very high antibody titer, it's called, or amount of antibody in my blood. If you give that to a patient, they actually do better because there's so many antibodies in the blood. So we're learning a lot about how many antibodies are in the donation related to how effective it is. So we've learned things about patient positioning that have been very effective that were not the way we treated these viruses in the past. So there's been a tremendous learning curve in all of this, and it's making sure we basically listen to our critical care and our leaders and employ the best evidence as soon as possible. And that, I think NCH has done just tremendous at.
Yes, I'm saying that. That's excellent. Can you tell us or give us some insight to the differential, and I may butcher this word, but heterogeneity, I can't pronounce it, versus, you know, the herd mentality as far as the virus is concerned? How does that differentiate? And what does that mean to us?
So what we want is herd immunity, which is when about 70% of the population has been exposed or has immunity to the disease. So that's where if we get a vaccine, that'll be our quickest way to that. So that's what herd mentality means, or the herd immunity.
Okay, and heterogeneity, where they're talking about within the community, that, you know, you're not necessarily outside of your community, so there's a little different spread factor or whatever. How does that play into that, if at all?
So I think some of the heterogeneity that you're speaking about, and this we're yet to delineate, there's some early reports that people with A-type blood, that I have A positive blood, I may be more at risk for catching COVID or having a worse outcome. So that heterogeneity means what is my own personal reaction a little bit to that virus, and are there certain characteristics, whether it's a blood type or other factors that would then predict that I may have a worse survival than others. So I think blood type is one they're looking at. The other independent risk factors we talked about were more like age and obesity. But when you talk about heterogeneity, that's more how do I and my genetics make me more or less susceptible to the disease.
Okay, one more question on COVID, and then I'd like to talk about a couple of other areas if we can, Paul, during our time together. And that is with respect to disseminating the vaccine. You know, what is the discussion? What are you hearing as a healthcare facility as to how that might need to occur? And what should we be expecting along those lines?
Well, Kim, great question. So like I said, one of the things we wanted to make sure of is that we'll be ready and prepared to be a distribution center. We've let the governor's office know this. We've secured the refrigerated rooms and so forth to store the vaccination. And we have, I think, a process now that we would modify to be a distribution point. It would be a modification of how we did the testing here. Very similar. So we will be ready. We're in touch with some of the distributors, and really we're just waiting to find out now about the approval, I think, right, Doctor?
No,
So what are they
absolutely.
sharing with you, Paul and Doctor, relative to who would be getting the vaccine first? You know, would it be a certain risk candidate patient? Would it be age related? You know, are you hearing anything along those lines of how they will want to disseminate it to be most effective?
So those are great questions, Kim. I mean, I think it's a little bit like what we did with the remdesivir, making sure that we were getting allocated, and so having that constant communication at the state and federal levels. But I think it will probably be healthcare workers. And then where we go from there, we will also look to guidance to some of our national agencies, and you would definitely want to consider some of the high-risk groups as well.
And I'm sure we'll learn more as time comes along, just like we've learned so much already in this short 6-month period. You know, you talked about the simulation, the training, the quality initiatives with some of the things that the hospital has done. Can you speak to some of the focus areas that you're looking at in overall healthcare? What is the strategic, you know, vision of the hospital? What areas will they be concentrating on, you know, coming up the next 12, 24 months? What are you looking at?
Boy, it's a great question. So here, I'll give you the short version, but you know, NCH has a really great footprint to start with, Kim. We have 2 really great acute care hospitals, one in the north and one here in Naples. We have 5 other sort of outpatient urgent care / freestanding emergency departments. And then we've got a network of 250 physicians and advanced practice providers out in the community. So that's the starting point. Our footprint now will expand a little bit into some of the growth areas in Collier County, maybe north and east. And we'll try to expand our network of primary care so people can get care closer to where they live in a cost setting that's cheaper than a hospital. So that's priority number 1, to improve the overall access to care for everybody that lives here. And then we will begin, as I said, by starting with heart and stroke, and then follow that with orthopedics and oncology care. And that will be our focus area. And as I said, we'll be making some announcements around imaging and some real big improvements around X-ray, CT, MRI, and PET scanning. And we're really excited about that because we have invested pretty heavily in artificial intelligence here as it relates to imaging. So folks will want to know that, and they'll want to really be a part of our imaging network to get the latest and the greatest for their X-rays.
How can folks, as you know, as you look at this vision going out, and you know, I've been in the community a long time. Paul, and seeing how we have evolved as a community relative to healthcare, and seeing Naples really becoming, or Collier County becoming, a destination spot for certain types of medical treatments, surgical, et cetera. So we've come a long, long way. And I guess the question would be, if you had to look out over the next 4 or 5 years, where would you envision we'll need to make the greatest movement to have the greatest impact in our community as it is anticipated to grow here over the next several years?
Great question. So we have a couple. I think one of the big ones that we've identified here is that folks dealing with cancer, right now it's a little bit fragmented in Southwest Florida. People are having to drive to different places. So one of the things that we're working on with the doctors is how do we better coordinate cancer care and perhaps make it a one-stop shop for people dealing with that disease from the standpoint of diagnosis, treatment, follow-up, all those different things. So cancer will clearly be one area that we have to look at. But the more immediate one is this whole notion of cardiology, and really taking ourselves to a level that we envision this becoming a destination spot for cardiac care where people would actively want to come here to be treated.
That's excellent. Well, you know, that's something near and dear to my heart, and that's what initially got me involved with the hospital a long time ago, to help support the growth of the quality of care in our community. Can you talk, Paul, a little bit to, if someone wants to support some of these initiatives, you know, how would they go about that? What can you share with us along those lines?
Well, the Center for Philanthropy is actively talking with folks right now in the two big areas that I mentioned. One is this idea around an endowed chair for cardiology that would allow us to recruit in a national figure around cardiology and give that physician time to do speaking and research as well as treating patients. So you think of the big universities with these endowed chairs. And we're not a university hospital, but we're going to be taking in some of this important research, teaching, speaking, and working with the physician community here to elevate. And that really is near and dear to many people's hearts, just like it is yours. And they want to support that through a named endowed chair. And that would be certainly one area that folks could get involved in. And the other big one is, if you're into technology and so forth, when people learn about the simulation center, I think they're going to get really excited about the robotics in that and how it will allow us to train doctors and nurses and other clinicians at a level far faster than ever before. So those are a couple of the big ones.
They're not learning on a real patient initially, right?
Yes.
Yeah, I think the technology you're going to see in the simulation center is really cutting edge. And it's not just the hospital that benefits, it's the community, it's the EMTs, it's the police, it's others who have to do some of these life-saving procedures that will all improve in the same way. So I think it is a really exciting opportunity.
And Kim, I might end on one that we don't talk much about. You know, Naples sometimes has this image of being a real older community, but we were just notified last week that NCH was named in the top 5% of health systems nationally for obstetrics and gynecology. So women's services here, it's a big deal. You know, we do 3,000 deliveries a year here. We have an excellent team of women's health doctors, including breast surgeons and breast imagers. So women that need mammograms, it is something that we do, I think, extremely well, but we don't talk about it very much. And that will be, you'll hear more about that in the days and the weeks ahead.
Right. No, I would love to add to that, because we have not only the general, make sure that, you know, the obstetrical components, but we actually have a Harvard-trained physician with us who helps with our complex moms in terms of ultrasound and making sure that we're ready when those babies are born. So we have a lot of technology and investment in talent around our maternal fetal medicine, which is a program that is pretty high tech too. So we have a lot of infrastructure for that, and we need both when we deliver babies.
That's excellent to hear. Well, as we're getting close to our wrap-up time, any final comments you'd like to make before we close up here?
Well, I would end maybe the way I started by just saying thank you, because I mean, the generosity of this community is really kind of unmatchable. It's unbelievable. And I just finished my first year anniversary of being here, and I've been amazed at how people want to be involved. This is the community's healthcare system. It belongs to the people of Naples. And man, they show it by their support in so many different ways. And we're all here grateful and honored to be a part of that. So thank you, and thanks to your clients.
Well, and I have to say thank you back, because, you know, the mission statement of NCH has not been about fixing people when they come in the hospital. It's about wellness and prevention. And that change in that mission statement has meant an awful lot to our community and the quality of care we receive here. So I'm going to put that right back to you, Paul and Kristen, to say thank you. Thank you so much for your efforts, the work you do. And I want to thank everybody out there and our family community who have joined us today. And please feel free, if there's any topic of interest for any future webinars, we're here to listen and make it happen, because wellness, health, family, generational planning, community, faith, and of course, money and security all play a major factor in our lives. So please tune in again in the future. Thank you again, and have a terrific day, everybody. Make it blessed and wonderful. Thank you. Bye-bye, and thank you, Dakota, for helping us out today.
Absolutely, happy to help.